integrating congenital condition screening, diagnosis, lifelong diagnosis. Ooh, we've got to mute that. Should you? Sure, the sound is all the way down, and then we're muted. Okay, I think we're good. Okay. Welcome to Building Healthy Futures, integrating congenital conditions, screening, diagnosis, and lifelong care into maternal and child health programs. I'm Katie Kraft, the Advocacy Program Manager from Children's HeartLink, and we could not pull an event together like this without a lot of teamwork, so I want to thank all of the organizations and partners who helped bring us here today, the Global Clubfoot Initiative, Butterfly Global Health, Operation Smile, Research, Revity, Japigo, Miracle Feet, G4 Alliance, Global Arch, and of course, Children's HeartLink. I am going to set the stage a little bit here before we roll right into the program. And in thinking about that, we're reflecting on just how we're at a really critical moment of momentum around congenital conditions. That I'm going to introduce Dr. Kate Strong of the WHO, who will give us a presentation. Kate, welcome. Thanks so much for being here.
Thanks, Katie. You can hear me, you can see my slides, and I can. Is there an echo? No, it's okay.
There's an echo.
Okay. So we'll have the first slide. So what I'm going to do today is just give you some background, sort of set the scene for the presentations that you will hear for the rest of the session. We have an overview of some of the statistics that we are working on at the moment. We'll go into some of the tools that WHO has provided for guidance, and then we'll talk a little bit about the framework for newborn screening and some of the recommendations that will come out of that. So we will get the first slide up, and then we will be right on our way. I have a lot of really pretty pictures with bright colors. That's because it's very early in the morning, and so it'll. That's right. Yeah, absolutely. Here we go. Okay. So, well, wait, now well, you don't need the title, right? So I've told you what we're going to do. And what we're going to say about this is, well, so we're working towards the SDG targets for child newborn survival. And as we can see, and as we know from the advocacy work that we've done and what's produced by the WHO, is that child survival has improved greatly over the last 3 decades. In fact, since 2000, the decline has been over 50% in under 5 deaths. Nonetheless, we have an estimated 4.8 million children that died under 5 from mainly preventable causes, and 2.3 million of these were newborns. 60 countries will not be on track to meet the SDG target of at least as low as 25 deaths per 1,000 live births, and 65 will not meet the target by 2030 for newborn deaths of at least 12 per 1,000 live births. So what we do know is that surveillance, prevention, and providing care for children with congenital anomalies, these are really important strategies to meeting our SDG targets. And what we'll see when we go to the next slide, which you've already had a preview of. And so the next slide, there it is. There it is. So the leading causes of under 5 mortality are prematurity, interpartum events, but also acute respiratory infections, malaria, and diarrhea. But congenital anomalies make up 8% of all under 5 deaths and 10% of all newborn deaths. And if we see this pattern across the years from 2000 to 2021, our latest estimates, this pattern of global mortality has remained largely unchanged. There's been no movement here at the station, except for this increase, as you can see in the bottom that I've circled. Congenital anomalies have been gradually increasing to 8%. Now we know that children born with congenital conditions are more susceptible to to dying from the leading causes of under 5 mortality, from the pneumonias, from malaria, from diarrheal diseases. And so this figure here really masks the mortality burden for those born with congenital conditions. This is why it's really important to identify and treat and manage these conditions early in the newborn period. Now, if we look at specific causes, so within the congenital conditions, what are the leading causes of death? Well, congenital heart diseases make the largest contribution. We have an undescribed category here of severe congenital anomalies. Then, of course, the neural tube defects, sickle cell disease, and the trisomies combined. And if we start to look at this a little more detailed with the next slide, I'm not winning with the, no, that's not the next slide. So just one more slide. Okay, so this is new data. So we have updated a data source called the Model Global Database. And within the model that's been used here, we have we look at the distribution of live birth prevalence of congenital conditions. And you can see here, it's very picture. So where we have the most countries off track for SDGs for under 5 and newborn mortality, we have quite high live birth prevalence of congenital conditions. And if we start to dig into this a little bit with the next slide, I've given up largely on the clicker. So I'm relying. Okay, there we go. If we start to dig into this, what are the percentage of global birth prevalence for congenital conditions? Well, we have severe and less severe anomalies, congenital heart anomalies, sickle cell disease, neural tube defects, oral facial clefts, and then the trisomies combined. So recent data here, and now we have this for every country in the world. And so we're going to be working on preparing that and presenting it in future talks. So we go to the next slide. And we can look at this regionally. And what we see is for congenital heart anomalies and the trisomies, there's very little very regional variation here. But in some regions, mainly the African region, we have quite a different pattern, with sickle cell disease making a huge contribution to live birth prevalence. And there's some other conditions. Oral facial clefts very high in the Western Pacific, neural tube defects, Southeast Asia, and of course, sickle cell and the thalassemias show regional variation. So we have some very specific things to look at for specific countries. And so countries need to think about how to plan for this, how to identify the conditions that may be of most importance to them. So can we go on to that's the whole point of this burden. Doing the analysis of the burden is to see how we can make the best and most efficient use of resources. So target those conditions that are the most prevalent in our countries and even subnationally. WHO and partners are working to improve this data through birth defect surveillance guidance. And so we now have second editions of all these things, a manual for program managers, a quick reference handbook, a facilitator's guide, and I put the links to the facilitator's guide in the workbook, which have just been released. And so these are things that will help countries identify the visible congenital anomalies so that we can code them, we can improve the data coming from countries, which will, of course, improve our estimates and improve the ability of countries to plan screening programs. So if we move on to the next slide, we also have another very important activity to improve birth defect surveillance, and this is what we call the digital adaptation kit. And it's basically the requirements to produce a decision support system for congenital anomaly surveillance within primary health care. So the guidance here for developing a digital information system for countries so that you can use this in centers, you can see the condition, you can record the condition, and that data can go into the surveillance system. So this is something that will be released very shortly, the whole guide, the digital adaptation kit, so that countries can take it up and start using this to develop platforms that can be automated in countries. So now let's talk about the next area of work. Well, it's not that quite the next area of work. We have one more thing to say here. We have a lot of challenges to continuing this work within not only the global WHO, but also on the global scale. We need resources and investments because right now they're very limited. And we need those to sustain and improve surveillance in countries, but also improve prevention. So increase public awareness and access to both prenatal and postnatal screening, the prevention programs for nutritional supplementation and fortification, rubella immunization, and all sorts of access to quality peri-conception and antenatal care, but also for improving the care of those born with congenital conditions. So increasing the quality of multidisciplinary care so that we have complete range of services that are available and either free or at low cost for families. Now, if we move on to a very exciting activity that is coming, a framework for newborn screening in low and middle income countries. And this is an initiative that has come from what I've just shared with you, the knowledge that congenital conditions are on the increase, and they're becoming a very important cause of both morbidity and mortality around the world. Yet few low and middle income countries have developed initiatives that are actually integrated into their health systems. And that is important because without integration, you can't sustain these. So the framework for newborn screening has asked countries a set of questions. When countries that actually have these programs, when did they start? How did they start? Which conditions did they start with? Which services did they have to strengthen to provide a screening? What infrastructure and human resources were necessary? And the question, is this really feasible for all countries? So how did this start? We look at the next slide. We've had this consultation. These are online consultations and participants are welcome. They started in 2024 in September and they just finished. The last consultation was just last month. And we had participants from 30 countries. They ranged from ministries of health to academics to NGOs to parents to people living with the conditions, covering a range of these conditions and making sure that people who are affected by the diseases and family members were part of the planning for this consultation and also were able to participate and share their lived experience. And so for the next slide, why was this needed? Well, screening programs started in different ways. There's no standard way to start a screening program. And there are lots of common experiences from countries that were able to be shared and they could review the challenges, but also the successes from programs that are now running. Low and middle income countries want to learn from others that have these screening initiatives, especially those that are government run and well integrated into health services and health systems. And so the platform will become a cross-learning platform for other programs. But the framework is not a guideline. It's intended to support the thinking, planning, and implementation of newborn screening at the national level, raising the importance of the area, addressing the planning together with diagnosis and management. And I think if you click again, you'll have the little box pop up with the aim to support program managers and ministries to plan the implementation of services for infants and to integrate these into health systems. So next slide. Next steps. Well, this consultation was very intense. Lots of information was shared from many countries. They had examples from India, Uganda, Egypt, Brazil, and the Philippines. And now is the time to gather that information together, to synthesize it, and to produce a document that will bring that information together and answer the questions, how were the first conditions selected? How were initial choices made? Hopefully based on the burden, some of the live birth prevalence that I showed you and mortality. What have been the challenges to integration? How have health systems been prepared and strengthened to cater to management requirements? And the financing, how are we going to fund this in countries? This is a big question. And what measures are in place to reduce stigma and provide support to families when they need it most? And now I'll finish with, with a summary here. So I think what I tried to get across to you this morning was that congenital anomalies are key to achieving the Sustainable Development Goals for newborn and child survival. And what's important about the Sustainable Development Goals is that they really are trying to bring equity into the picture to make sure that we leave no but one behind, especially the most vulnerable populations. The most vulnerable populations are people living with congenital conditions, so we don't leave them behind. They're supported so that they can live healthier and longer lives. And we need to make sure that we integrate screening, management, and care into the health systems to save and improve the young lives of people everywhere. So thank you very much for your attention today. And hopefully we will move right into the next session, which is a panel discussion.
Okay, Strong, thank you so much for your intervention today. And great job dealing with the clicker, no clicker situation and still delivering on the message. Good morning, everybody. Really thrilled to have you with us today. Hope some of you got some coffee. I'm Dr. Ruben Ayala, I'm the Chief Policy and Advocacy Officer for Operation Smile. And on behalf of the Global Alliance for Congenital Conditions, it's once again a pleasure to welcome you today. Want to really thank you for taking the time. I would like to express our gratitude also to Dr. Kate Strong and our colleagues at the World Health Organization. As you can see, they've done a significant amount of work to go through the science, the epidemiology, to understand the massive size of the need, and to help us make a case for action. And today, we're very privileged to welcome representatives from different governments who already have raised their hand and said, this matters to us so much so that we want to join you not only today, but along the journey. We have representatives from Ecuador, from Namibia, from Angola, and also from Saudi Arabia. We have two representatives from Pakistan and Vietnam who are still at the airport in Istanbul, but it's good to acknowledge them as well. So what we'll do today to welcome these experts and instead of reading all the bios, you have them in the program. I would highlight that all of them have extensive experience in service delivery, in health service planning, in academia, in public service, and in health system strengthening. So really it's a privilege to welcome them today. I would like to begin by welcoming our dear friend, Dr. Alfredo Borrero, former Vice President of Ecuador, to say a few words. And Dr. Borrero, what we'd love to do with you and also with the members of the different countries represented today is if you will welcome us with a few words, and then we'll ask you to sit down, and we'll then go ahead with some questions for you. Dr. Borrero, welcome this morning to this forum. Thrilled to have you here. And I get to have the privilege of giving our dear friend Maria Jose a break from her translating duties. So bear with me.
Good morning, everyone. Es un privilegio para mí estar aquí. Me voy a dirigir en español porque 800 millones de personas en el mundo, en Ibero, Latinoamérica, hablan español.
Very good morning to all of you. I'm going to speak Spanish to you because as a reminder that 800 million people in Iberoamerica speak Spanish.
Voy a hablar por esos niños y esas madres que hablan lenguajes que solo ellos entienden y que no hablan ni inglés ni español.
And I'd like to acknowledge and hopefully speak on behalf of those children and mothers who speak languages that many of us might never understand, and certainly not Spanish nor English.
Quiero saludarles a este grupo de gente inteligente con corazones comprometidos.
I want to say hello to this group of smart and people with committed hearts,
con una causa que toca lo más esencial de nuestra humanidad.
and committed to a cause that touches on the most essential areas of our humanity.
El derecho de cada niño y niña a una vida digna, saludable y plena desde su primera infancia.
The right of every child to a life of dignity and fulfillment from the moment they come into this world.
Yo soy médico, soy neurocirujano. Tuve la oportunidad de servir a mi país como vicepresidente.
I'm a physician, I'm a neurosurgeon, and had the opportunity to serve my country as a vice president.
¿Qué hemos aprendido? Hemos aprendido que cuando los sistemas de salud incorporan desde sus cimientos la detección, el diagnóstico y la atención oportuna de condiciones congénitas, estamos construyendo futuros saludables.
We've learned many things, and one big lesson we want to share today is that if we incorporate very early on the diagnosis, treatment, and lifelong care, then we're building a better system.
Este no solo es un acto médico, es una declaración de humanidad.
This is not a medical act, it's a declaration of humanity.
Es una promesa que debemos cumplir a las madres y a los niños del mundo.
It's a promise we must fulfill for the mothers and children in the world.
Demostrar que la vida sí nos importa,
To demonstrate that life indeed matters,
que debe transcurrir sin sufrimiento
that there shall be no suffering,
y que si este existiese, debemos tratar de disminuir.
and if there's suffering exists indeed, we should do our best to address it.
Pero este compromiso va más allá de una serie de pruebas, de exámenes y de una lista larga de intervenciones quirúrgicas.
But this commitment goes beyond a list of long list of consultations and exams and a long list of surgical interventions.
En nuestra América Latina no podemos hablar de equidad sin hablar de interculturalidad.
In Latin America, we cannot talk about equity without talking about interculturality or interculturalism.
Muchas de nuestras comunidades indígenas tienen cosmovisiones diferentes.
Many of our indigenous communities have different cosmovisions
Sobre la vida, la salud, el origen y el sentido de las malformaciones.
about life, health, the origin and the sense of the existence of congenital conditions.
Y nosotros, todos nosotros, debemos llegar con respeto, con humildad y, claro, con ciencia.
And all of us should address that with respect, humility, and of course, with science.
Debemos integrar la sabiduría ancestral con el conocimiento biomédico.
Integrating ancestral wisdom with medical knowledge.
Construyendo puentes, caminos, no dividiendo ni profundizando las diferencias.
Building bridges rather than dividing.
Eso es una obligación. Debemos incorporar en los protocolos de salud materno-infantil.
This is an obligation which we should incorporate in the protocols of maternal and child health.
Porque lo que está en juego es una vida de un niño o niña que nazca, que sea comprendido y que lo trate con dignidad.
Because what's at stake is the life of a child who is coming into this world and deserves to be treated with dignity.
Y queridos amigos y amigas, esto no depende del lugar o de dónde vive.
This does not depend on the place, should not depend on the place or the last name or where they might come from.
Tenemos mucho por hacer. Porque tenemos una deuda histórica de la salud pública con las comunidades de difícil acceso.
We have much to do. We have a historical debt with those communities that are hard to reach.
Los pueblos tienen una herida abierta y nosotros debemos tratar de cerrar.
Around the world and the hardest to reach places have an open wound that we must close.
Más allá de las reformas técnicas, de los marcos legales, de la burocracia, debemos comprometernos con una visión integradora que ubique a cada madre, a cada niño y a cada comunidad en el centro de nuestras vidas y acciones.
Well beyond any technical policies on bureaucracy, we must center our activity and our actions around the mothers and children and their well-being as must be part of a core of our activities in life.
Hagamos pues todos un esfuerzo global.
Let's make an effort.
No intervenciones independientes, unilaterales. Esto es una tarea de todos.
Not unilateralism. This is a task that belongs to all of us.
Forjemos un movimiento de justicia, de respeto y de empatía.
We have a chance to create a movement of justice, respect, and empathy.
Lo debemos a las poblaciones abandonadas y marginadas.
We owe it to our people, especially those we have forgotten along the way.
Cada niño o niña que nace con un problema congénito
Every child who's born with a congenital condition
tiene derecho no solo a vivir, sino a vivir bien.
has a right not only to live, but to live well.
Y esto se consigue con soluciones valientes y con decisión.
This can be achieved with brave solutions and with the right choices.
Gracias a todos ustedes, a sus organizaciones, por no renunciar a la esperanza.
Thank you to all of you and to your organizations for not giving up on hope.
Gracias por poner a las soluciones parte de su corazón. Muy buenos días.
Thanks for bringing solutions, hard solutions, into action. Good morning. Well, you join us. Thank you, Dr. Borrero, for such wonderful words and message, and for your long history of engagement. I would like to welcome now Dr. Noemi Shupala, who's the Director of Primary Healthcare Services of the Ministry of Health and Social Services of Namibia. And Dr. Shupala, if I might say thank you this morning for opening the door for all of us who showed up here at 6:10. She was ready to go.
I thought you would stand by here so I can speak in my local language.
Oh my gosh. I wish. I'll do my homework next time.
Thank you once again. I'm privileged to stand here in front of the expert in the congenital conditions. I have worked in the primary healthcare arena for the last 30 years. However, I should confess that while we are doing a lot, we have not taken that dedicated focus to advance the prevention, health promotion, and management of congenital condition in a broader scheme of things. But I should also share with you that we have a very dedicated clinical team that is working on the congenital heart disease. Our wish is that we pull up all the other conditions in terms of the focus and attention as we are doing with the congenital heart diseases. I really want to appreciate the organizer of this meeting for inviting us to be here, to be at the table as policymaker and be able to take this focus when we are sitting at other table, whether it's in terms of lawmaking or domestic resource mobilization. I would like to shout out to someone very special in this gathering, Martha, seated over there. Thank you, Martha. By the way, Martha and I met because she worked in a directorate that I have overseen. And she's one person who has empowered me when it comes to the congenital conditions. How I wish that I have met her earlier, that by this time the country would have advanced in terms of the congenital condition, policy making and integration into PAC. I should highlight that for a setting like Namibia, we are fortunate to have a primary healthcare approach, which was adopted after independence in 1990, which means services are available at all levels for free, and it's integrated services. We are providing maternal and natal and child health services for free, and this is an opportunity for the integration of health promotion, prevention, and control of congenital diseases. I also want to highlight that financing is very important. And at a time, we are implementing this program in silo as vertical program. However, when we do that, we risk when it comes to sustainability. However, when we start off with the integration of this program into existing mainstream program, there is an increased opportunity to ensure the sustainability of this intervention. And that is the case that we are looking at for Namibia, to ensure that the whole program of congenital conditions is fully integrated in maternal and child health services. There are opportunities and lessons that we have learned from other programs, whether it's HIV, or what we need to do is to take this lesson and apply them
into how we make the congenital condition programming successful. I also want to highlight that there is great opportunity for spillover effect if we invest now in the congenital condition management. In terms of improving maternal health services overall, if we integrate the congenital condition into MNCH, improving the child health services, improving nutrition through this integration, but also improving the health workforce capacity, equipment, and infrastructure. I just want to end by saying the time is now, and for us as policymakers, we are ready and prepared to undertake this journey. Thank you.
Thank you so much. Thank you so much, Dr. Shabbat. What a lovely statement for policymakers to say, time is now and we're ready. We're going to take you your word, and we're excited to work with you. I would like to now welcome Dr. Ahmed Ashrafrani, who's the CEO of the Health Academy of the Saudi Commission for Health Specialties. Dr. Ashrafrani, welcome.
Good. It's a pleasure to be here, and we are discussing very important issue. Before we go into the discussion, maybe I would like to highlight what context we're going to talk about from our perspective. We are going and discussing not the clinical parts, because we care about our healthcare practitioner, their well-being, and what's the impact that will be created when it comes to discuss such critical conditions that affects each of our countries, regardless of your economic power and impact. We still have these issues, and it still affect us because it's not a preventable disease. So for sure, we have experiences to share, and I would like to highlight that from the perspective of healthcare practitioner, we are going to discuss that today. It's a pleasure actually to be here, and it's an honor to be with you, my colleagues, and discuss this matter. As I mentioned, we are going to share our approach and to this challenge from the lens of workforce development. We are lucky at the Saudi Commission, so I'll give you a context about Saudi Commission of Health Specialties. We are different and unique health regulatory body that are responsible of covering the entire professional journey of the healthcare workforce, starting from higher education, credentialing, assessment, licensing, and clinical standard practice. This huge mandates for all healthcare practitioners, whether they are physicians, dentists, pharmacists, and allied health nurses. They are all governed and supervised by the Saudi Commission for Health Specialties. This comprehensive mandate gives us a responsibility to ensure that our workforce with the knowledge and skills is such conditions that impact the youngest and most vulnerable patients in our communities. In Saudi Arabia, this is very important and crucial matter. It's a national priority for the Saudi Arabia that they put just only for child and their health. It's part of the Saudi model of care that we are going through now in the transformation. So it's very crucial to us. Have established, and the Ministry of Health have launched a national newborn screening program for early detection and prevent and timely interfere when it comes to that. This is only possible again because we have trained healthcare professionals that know how to deal with the technologies, to deal with the advancements of all the analytics, not only physician or pediatrician, but even allied health are part of this journey. Screening itself, it's not the issue. Moving from screening into equitable access, I think it's one of the challenges we face and we raise, regardless of our GDP in the kingdom. Equitable access is still an issue, especially in remote areas. So this is one of the things that's why we are very advocating the child and women health and why congenital heart diseases is a cornerstone in delivery of care in Saudi Arabia. We launched also the Saudi Genome Program, which is very important because we are in the area of the Middle East, we have different genome profiles and we have different conditional diseases that are in the area. So this has helped us in actually identifying and reducing the prevalence rate or even improving the survival rate. When we have Saudi Genome Program that is specialized for early detection, and we have, with that, developed capability as Saudi Commission to serve better lab, focusing on the allied health profession. My background is pharmacy. So I'm a pharmacist by practice. I shifted into public health and my focus in health policy. Now I'm leading an academic entity that's helped provide all the competencies that our healthcare professionals, so broader spectrum that I have. But one thing I want to highlight here, policy progress happens not only from government, not only from entities, but non-profit organizations and health practitioner societies. They should be part of this conversation because they advocate, they support for patients, and even patient support group is very important to be listened to and heard to when actually talking about such a disease, because those variables and those patients, we believe they have different way of dealing with the disease, because sometimes stays forever regardless of what you do. So we believe a collective support, a collective intervention from policy from top down to the government, public-private partnership in providing analytics and extra, plus non-profit organizations such as societies or patient support group, they should play a major role in that. At the Saudi Commission for Health Specialities, we are committed to supporting all this ecosystem by developing healthcare practitioners up to the standard to address congenital condition. We believe this is not only a medical issue or medical challenge, it's also a workforce challenge as we see it, because the direct care is provided by healthcare practitioners. And we believe that investing in these people who deliver care, we ensure that children born with those conditions have the best choice, not to survive, but to thrive. Thank you very much.
Thank you so much, Dr. Asumani. And you start to see different approaches. We've heard about the points of integration, hope, primary healthcare approaches, and a policy that turns into action. I'd now like to call Dr. Maria de Gloria Costa Mabuete, cardiology lead for pediatric cardiology lead for the Ministry of Health of Angola. Welcome, Dr. Costa Mabuete.
Hi, good morning, everyone. Thank you first for being invited to this conference and our representing the Minister of Health in the country and being able to share a little bit of what we're facing in Angola as a country. I know that we know Angola is a Portuguese-speaking country, so we started with Spanish and then we got to Portuguese, but I don't think I will have anyone translating. Ah, so bless you. Okay, so so, and I would like just to say to you that, of course, the maternal and child health is a challenge for our country. We know we are 30 million people country, and we have a very high fertility rate. It's almost mandatory to the women. It's part of their existence to have children. So we have almost five for every woman. And with this, this bring a lot of challenges to us as a country that lived a civil war and now has to and always deal with infectious disease and child mortality associated with infectious disease, and now has to shift a little bit to these conditions that for a long time had been not diagnosed or even talked about. And now we're seeing more because our people are more aware about it. And we have more, we are building our workforce, healthcare workforce, and they're more pay more attention to these conditions, and now we are being referred a little bit more, and so we have to think on how to change it and how to deal with this new reality. But because we still have strong infectious conditions in ours, we have diarrheas, we do still have HIV, tuberculosis, all these, they have a bit of, not a bit, a lot of burden in our healthcare system, and everybody's toward malaria. And when we're trying to think about congenital conditions, it's more difficult because it needs for us to have more equipment, another type of infrastructure, and only now our government in these last years is trying to tackle this, building new hospitals and dedicated hospitals for maternal child health and also for other cardiovascular diseases, so that we can address a little bit more and with more efficacy this kind of disease. So in short, we don't have many data, unfortunately, still. And we have some pilot studies done, and the disease that we had, I think, in newborn screening that is going well or better is the sickle cell disease, that you know that almost 3% of our children are born with sickle cell disease. We have on this 20%, they will have the disease. And so we started this program in 2000, the government started in 2011, the screening of these children during vaccination, immunization periods. And they were able to really support, like put 90% of these cases linked to care. So now it's a pilot program that is being extended to other places, like 11 hospitals in Luanda and maybe 11 hospitals in Cabinda, but we still not being able to leverage to the rest of the country. So this is also a problem. The country is big, it's really big, and we have very rural areas that are difficult to access. And in the culture of the country also, we still have some suspicion about medicine, going to the hospital, so people don't go to the hospital immediately. We still have a lack of postnatally, the children are only about under 25% go to the hospital when they're sick to look for help. Majority, they stay at home, they do traditional treatments. So until the time they go to us, it's sometimes it's too late, and they come in the worst conditions. So this is all these things we have to deal with, and then funding also the system. It's also a problem. And trying to build the workforce. The government has now a program running, and to train more healthcare professionals. We are doing it locally in the country with the help with partnerships with private sector, and also We are doing it, sending people abroad. We have the Bank World's financing training program for maybe 38,000 professionals. So we hope. And in terms of primary care, they're really now also addressing that. They have 4,000 people now in training, the nurses and doctors, so that we can have a more communitary workforce, and we can be able, and also dedicated to child health, and be able to tackle all these problems. So there's a lot of things going on. And then we're starting to also, we started also the pediatric cardiac program, and it's a very embryonic phase, but we are trying to gather and put everything together. It's difficult because we need a team, and a team with a very skilled team, and it takes time, and the problem is already there, and we have to address it. But still, we're giving the steps necessary to go to there. So it's actually we still have to formally integrate congenital conditions into maternal child health strategy. We started, but we still have a lot to do, and so that we can see if start also trying to start to screening. Screening is very important. It also gives us that data about the things, and then we can just move further, actually, to leave no child behind and try to build a healthy future for our children. Thank you.
Thank you so much, Dr. Maguete. Well, I have a ton of questions, but we have a wonderful surprise for you and for the audience too. We're going to be hearing from patients, former patients, patient ambassadors, whose voices bring us back to the realities you as leaders are also trying to address. So I'm just going to ask one question instead of the many that I have, and I did have many. But it's hopefully it's pretty straightforward. You have a group of advocates here, people who are willing to join along in this important effort. So as advocates or partners, what can we do better? What would be the most useful for you to feel our support or our engagement, or to walk along the path with you in order to increase investments and prioritization of patients with congenital conditions? In a way, we're saying, what can we do to work with you as you lead these programs? And who wants to go first? Yeah, she actually said she was ready.
Thank you once again. I'll say advocacy, advocacy, advocacy. Secondly, I'll say data, because they speak volume. But as you know, as I was preparing to come here, when I get an invitation, I would want to get a hold of what data is there. Yeah, so we need, yeah, so true. We need a lot of data at the country level, and you are in the position to be able to facilitate that, to ensure that country have got those systems, because there might be countries that are already doing well in terms of their data system or monitoring system, but with eagle kind of an overview of what is happening in one country, we'll be able to help others to get the correct data, research and study, and to share some of the recommendations from those studies. A body like WHO and other partners, you are also sitting with at high-level meeting. I don't know how the subject of congenital condition is highlighted at the UN high-level meeting. We have one upcoming in September. How do we make sure that it's on the agenda? So that is how we think you can support governments to ensure that this is integrated in financing, budgets, and policy. Thank you.
No, go ahead. Everybody's so polite. No, you go.
One of the biggest problems in our Latin American country is the or nothing in the registration. In some countries in the Amazonic River, in the jungle, some not contacted people think that the congenital condition is a attribution of the supreme, and this is a very, very big problem. When we have registration, if the people go to the hospital or to health campaign, but some of these people don't go to the campaigns of health, and this is a very big, big problem. And the kids' death, in some case, death the kids and the mother. We need more contact with the people that take 10 hours in river, in the jungle to come hospitalization or service of health.
I would agree with my colleagues. Data-driven advocacy, I think, is very important. We could call it this way because it shows the mortality rate, the social and economic impact of these diseases on the decision maker, on the policy, on the life of people who actually suffer from this disease. Second point, I think it's very important for the group. That's highlighting success stories and the beginning of investments from other country experiences. And I think this is the platform for sharing these success stories. WHO 5 platforms for us to share. We can't move forward without, again, advocacy. When it comes to advocacy, we should actually highlight the role of healthcare workforce in delivering the care, because policy don't deliver care.
All my colleagues already said, I think, everything, because I think we are on the same wave. Is data and advocacy, first of all, because without data we are blind. We cannot tackle. We don't know what we need, and we cannot actually achieve the goals that we need to achieve. Also, I think we can be help of technical assistance to design these cost effectiveness programs to help us being able to deliver the care that these children need. Other thing is actually not to separate congenital conditions from maternal child health, because we look at the under 5 mortality rate, and we know that congenital conditions are associated to this under 5 mortality rate. So it's important that we, for me as pediatric adults, I live in the congenital malformations. I see all of them most. And I can tell you that, for experience, that a child with a congenital condition cannot survive malaria, cannot survive any direct infection or pneumonia. They don't have the immunity to do that. They don't have strength to do that. So if we go to help to take this issue, as we can sort of speak, on the way in, be doing better for them and helping them to survive these diseases that are not really health problem, are more social, also economical, and conditions that need other involvement besides NIH involvement. And actually, and then in terms of some policies also, we need to really do better on that. And in small things as fortification of folic acid for tube defects, and some of the ideas. Thank you.
Thank you very much. Well, So much said, but I'll maybe recap. What I'm hearing from you, and hopefully our colleagues here will agree, is you're telling us don't separate congenital conditions from maternal child health. You're reminding us to continuously advocate. Help us with data, with the, and knowledge, do research. Help us address the barriers. Talk about cultural barriers, geographical barriers, financial barriers. Support the workforce, support for workforce. Reminder, policy does not deliver care, people deliver care. And for you who are also invested in policy, we would say to you, help us with the policy that supports the people that deliver care for the communities that still need care. Thank you very much. Thank you very much for listening. And now we go to the next section. I'd like to welcome my friend and colleague Kate, and she will have us with our patient ambassadors.
Thank you. Hi, everyone. All right. Can our panelists come up and take a seat, please? So good morning, everyone. My name is Kate Schmeck. I am the Executive Director of Global Arch. And I am thrilled to be here today. And it's just an honor to be able to moderate this panel with these incredible individuals. I think to echo what was said is that we believe for the Global Action for Congenital Conditions that everyone deserves a seat at the table. Policymakers, physicians, corporate, NGOs, and especially those with lived experience who are very often left out of those discussions. And when we pair data, thank you, Kate, and our partners at the WHO, when we pair data with the experiences of lived experience, we can even strengthen our advocacy more. So today, I'm joined by 3 powerful advocates who will share their lived experience and perspectives on how we can build a healthier, more just future. To leave plenty of time for discussion and to hear from these incredible individuals, we'll not do formal introductions. They'll share about their stories and more about themselves, but we encourage you to view more in the program and for their bios. So let's dive in. Martha. Martha is a passionate advocate whose journey with congenital heart disease, as we heard, has inspired her work in community education and support and empowerment of other patients and those around her. She's absolutely amazing. Martha, can you briefly share a little bit about your story and looking back, how my early screening, diagnosis, and lifelong care changed the path for you? Thank you so much.
I was born with a congenital heart defect, and I had my operation when I was 2 years old. And after that, I lived a normal life because I believed that I was cured. So, but only then when I was in my final year at the university, I started getting tired, and then I was diagnosed with a leaky valve, and I needed a valve replacement. So, I was then placed on a waiting list for surgery, and I stayed on the waiting list for some time. And this has been an issue because from my country, Namibia, we only have one trained cardiologist that cater for the whole country, and most of the kids have to be on the waiting list to wait for surgery. And then I managed to get the surgery, okay. And then later on, I had to have another operation again, but it was a valve replacement that was last year. I'm doing good. Like many families of patients with congenital defects, my family had to face other challenges, and this also included stigma. I think it's very important for people to understand the importance of awareness, and because it brings information to the people that are dealing or caring for children with heart defects. And one of the situations that my family faced, my parents faced with, was that they were told. So in my community, having a child with a birth defect, it seems like a taboo. So most of the time, they were told to either hide, or people are not forthcoming to discuss their children's defects. And some of the patients will go for traditional medicines because they believe it's not normal for a baby to have a heart, or to be born with a heart condition. And this was the reason that inspired me to to the support group, which is the bilateral health support group, to bring together the families and patients with congenital defect, so that they can be open to discuss their birth defects, and also to give support to one another. Thank you.
Thank you, Martha. That was wonderful. So I'll then turn to Petra. Petra is an advocate for people born with clubfoot, and she's also an Olympian. So Petra, based on your experience, why do you believe governments and health systems must prioritize congenital conditions as part of maternal and child health? And what could happen if they do not? What would the future look like?
Well, first of all, I want to thank you to have me here. It's an honor to be here. As said, I was born with clubfoot, and also hearing still now, for me, it's crazy that I've been to the Olympics. I was at the Olympics in Tokyo, but it's nothing which is normal. Like for me, it's not normal to have had a success, a story like this. I was one of the lucky ones. We have so many patients, baby, who are born with clubfoot. It's like 200,000 a year, which is incredible. It's such a big amount of babies who might not walk. They might not even be able to do a first step or climb. I've been a climber. Since a baby, I've always wanted to crawl up, go up, stand up. And seeing my mom, or hearing from my mom now, that it was really, really hard to see me as a baby with clubfoot, not knowing where the journey is going, not knowing what's going to happen with me. I'm from a sports family, so not knowing if I will be able to walk. And this, born in Switzerland, a really privileged country. I don't want to imagine how it is for all these moms, all these parents who give birth to a baby in lower middle income countries. This is where like 85% of all clubfoot babies are born, or big amount. And 85% of these 200,000 are from the low and middle income countries. So just imagining my mom being there, not getting the support, hurt, like stigma. It's a big, big problem. Like you see a baby, the foot is twisted. You don't know why. You don't know why it's your kid. Yeah. And for me, I've had an incredible career, and my journey is part of it. Every time a competition didn't go great, every time I had a rough day, I just remembered, for me, it's not normal to be here. For me, it's not given that I can climb, that I can be here, compete, and have such great success. Like, this is why it motivated me to keep on trying, standing up once more, giving it another chance, and seeing how privileged I am. And I think this is what's most important. It's like giving the kid the chance to live. It doesn't have to be a sports career, but just a normal life.
giving this kid the first step alone, being independent, giving back to economy, giving back to other families, being part of society. That's what we want, and that's what we want to see these babies grow up to be. And we've heard it from Alfredo in the first speech, hope. Hope is what we need, and I think it's why we're all here, because we believe we can make a change, and we all want to make this change together. And this hope is also why I'm here now, why we will be here always and fight for these kids who are not even born now. With all problems we have, this is one I burn for. I want to make this change, and it's amazing to be here. And thank you all also that you guys are here.
Thank you, Petra. Is this on? Yeah. Okay. Thank you. Yeah, I am a family member of multiple people living with congenital conditions, including congenital heart disease and cleft lip and cleft palate. And we hear all the time, including my own brother, the unknown of when he was diagnosed, what would his future look like? What does that look like? And also the afraid to share. He's a pilot, so he was afraid always to share that. And with that also is this matters, because this makes it this helps the stigma. This makes it that this community is working together to push forward and make the unknown more known. So thank you all. Amen. He is a leader using his voice across global platforms to advocate for people born with cleft lip and cleft palates. Who are you today, and how are you using your voice to advocate? With that, to add in the advocacy, is if you could ask world leaders to take one specific action today to better support people with congenital conditions, what would it be?
So, well, first of all, again, thank you so much for everyone. And I'm very happy to be among you today and be one of you. It's such a pleasure and such an honor for me. Well, the reality is actually the voice that you are hearing now was never meant to be heard. If things didn't go well, if hope wasn't there, as my colleague said, if action wasn't actually took at the right time, I would have been here. And my story is actually pretty long and pretty like there's a lot of miracles inside it. I have 6 minutes to speak. I need 6 times 20 to actually just put you in the image. But
I'm sorry.
it's okay. No worry. So I am actually here, and why I took the term because I believe for like a long time that I was less because I was born with a cleft, and I was always afraid to be seen, or I avoided roles. I didn't want to take a step forward and show myself because I was afraid of what people will say. I was afraid of what people will comment about me. But with time, I learned that the scar that you all see on my lip right now wasn't just a flaw. It was actually a beginning to something that I never expected. So speaking today is actually not just advocating for myself. It's actually advocating for millions of children all around the world. Have a voice. I was lucky to get one. Many others don't have that. And what I'm trying to say, or at least like the message that I'm trying to send you is actually I got lucky once. I'm very proud to have that chance. A lot of children are waiting, and when we say children, we only focalize on like patients, but behind patients there's mothers, there's families, and when we give the chance for one children, we don't just give it for one, we give it for like a whole family. And once you give a chance for a child, they will never speak for themselves, for others, just like I'm doing. And by myself, I'm not just a student, I'm not just a leader. Um, I am a child turning into a leader. I am a son who's made by purpose. I am a human too. So, and if I have to say something for the people here, actually, I'm interested by the talk of many of you, many leaders here. We have what we I could actually ask from you is actually to um, take action. Life waits, children are waiting, and just we need to have a beautiful answer if the future asks us, what did we do? We better have a very clever and beautiful answer. So, yeah, thank you so much, and um, thank you for all your work and your dedication for this purpose.
Thank you. I was a little strict on time. Sorry. Thank you, though, for all of our speakers. I think that we all have loved ones, friends or loved ones who are impacted by congenital conditions, whether in the past or now today. You have your friends here. And we have to, there's so many around the world waiting for care, and we have to do something. So both for congenital conditions, both invisible or visible, action needs to be taken. And so on that note, I want to end this panel with each of you sharing one thing you want people to remember, just in 1 or 2 sentences. You can go 3 if you want. And Petra, I'll start with you, and then Martha, and then Amen.
Well, I think the most important is, especially concerning clubfoot, it's often something which is overseen. It's something which you maybe find it's not like the most important to treat at the moment. It's not a heart disease. It's maybe not crucial in time for a bit, but I think it actually can really change a life. So yeah, it might not be that time critical, but it's definitely something which shouldn't be overlooked. We can make a big, big difference. And as already said, I think every patient will be really, really thankful and will give back in multiple times. So make the first step happen, and don't stop hoping.
I think one thing that I would like for people to get from this is that, like Dr. Chapara mentioned, advocacy saves lives. So it's very important for all of us to get involved, and let us advocate for screening. Let us advocate for quality health care for children with congenital heart defects or congenital defects. And for policymakers, I would like to say that it's very important for children with congenital defects to have access to quality care and on time. And with the WHA resolution form on integrating the onset childhood disease in the universal care, I think it will help children with congenital defects to have access to care and to care on time, and regardless of what or wherever they are finding themselves in. So let us advocate and stand with the families of children with the congenital defects. Thank you.
Say is actually for all children with mental conditions, we're not just data, we're not just numbers, lives, we're children. Action must be taken very soon. Because our future doctors, future leaders, future presidents, future let's and so is actually advocate and it's actually given to a child in the right time. So thank you so much.
Thank you to all of you. I think the takeaway words in particular are hope and action, and also longer, but standing with the families and the patients together. Include the voices of lived experience. Their impact is tremendous, as we saw here today. So thank you all for sharing your stories and for your call to actions. I know sharing your stories are not always easy, so thank you for that. Your experiences are not just powerful, but they're guiding lights for how we build systems that truly serve throughout the life of patients, not just at the initial treatment, but lifelong. Let's make sure these voices don't just speak today, but they shape what comes next. Thank you to each of you and to our audience, and thank you for all the action you take every day. I'll hand it over to Bishra for our next panel, and thank you, everyone.
Thank you, Kate, and for our patient advocates. So we have our one last panel, and that's a panel of broadly the private sector. So that's civil society, industry, and so I would like to invite our speakers here to come and join me. Again, Again, to save some time, we are going to do just brief introductions of everyone, but you can scan the QR code to learn more about our speakers. I think the last panel really, we ended with one sentence. Thank you for that, Ayman. That we're living proof of your work. And I think that that's exactly the people who we have here on the panel that have been working in different spheres around congenital conditions of what can be done and what the civil society and the private sector actually can be doing and is doing around congenital conditions. So we have prepared some questions. I don't know what their answers are going to be, but we have prepared questions, of course. And I would like to start with Daphne Sorensen, who is the Executive Director of Miracle Feet. And the first question is really from your experience, and your organization is I think about 11, 12, 10 years old, something like that? 15, okay. What do you think NGOs, the private sector, industry, what can we all do to really influence policies and to really influence policies about congenital conditions, on screening, management, everything that the WHO is doing? How can we facilitate more of that work?
Hey everyone, can you all hear me okay? Good. Good morning. It's great to be here. Thank you, Bistra. It's wonderful to be representing Miracle Feet, but also being part of this wonderful coalition of GAC and with so many folks in the room. I think we started hearing some answers to that question with the wonderful panel from government and ministers. You all said to us that you need data, and I'm going to give 3 answers, but I just want to break down the data piece for a minute, because it is so crucial. And what does that really mean, right? I think us as members of civil society organizations who really care about and want to move the needle on this work with congenital conditions, we understand that for decision makers at the Ministry of Health, whether it's Dr. Gloria, Dr. Noemi, others, to make decisions, you need some data. So just to give a little bit of an example and break that down, at Miracle Feet, we track the enrollment of every child born with clubfoot, and we're able to gather that information alongside the number of annual clubfoot births in every country. And we do this because, as you said, without this kind of information, somebody said you're driving or you're flying blind, which we never want anyone to do. And I'll give maybe example of 2 different countries. For example, in Nigeria, we know that 10,261 babies are born with clubfoot each year. And we know that currently about 14% of those are starting treatment before the age of 1. So when we can gather that kind of data, whether it's about clubfoot, whether it's about cleft lip and cleft palate, congenital heart disease, or any other condition, we are working alongside you, ministers, governments, to be able to say, what is the gap? How many children are we already reaching, and what is the gap for that? So I think being able to really understand what kind of data you need, what kind of data we can support, and how we're gathering that data in the way that is most connected to your own systems, HMIS and so forth. We don't want to create any duplicative systems. We want that data to be as integrated and as part of your own national health systems as possible. So I think the other piece of data that we collect at Miracle Feed, and I know many other organizations do as well, is, well, what is the cost of treatment? Because we understand prioritization, resources are very, very hard right now. And in the age of making sure that every dollar counts, how do we make sure that we're telling you what is the cost? And then, of course, the cost of investment. Once you're able to invest in treatment, what are the payouts, right? People need to be able to understand what is the cost of treatment, what is the cost of care, what is the cost associated with taking care in a dignified way for all babies and all children born with all sorts of congenital conditions. So I think, continuing to be a partner in that data gathering, continuing to be coming alongside governments on what data you need and what we can support is key. And then I think the other piece is being able to be very, from the very beginning, not being precious about the solution, but rather being very, very passionate about the problem that we're all trying to solve together. Whether it is clubfoot or congenital heart disease or cleft lip or cleft palate or any of the other congenital conditions, being able to understand that ministries, that health systems are going to have to simplify the way that they get the solution to the most number of babies possible. So whether we may have a program model that we know works isn't as important as how does that fit into your national health systems and your priorities. So I think really being very humble, I think, about coming together and saying, what is possible in this ecosystem? That's key, because we just want to get to all babies and we want to make sure that they all have the right to health care. And then the final thing is along the same lines, is not be precious about each other, in the sense that we all have to work together as a coalition. And I say this, I think this is a very important place to do it. We're here bringing together so many organizations who are part of the Global Action for Congenital Conditions with a QR code for others to join us. And we're being very intentional about speaking as one voice in this coalition. It matters so little about whether it's my organization or Ruben's or anyone else's. What matters here is advancing the right to healthcare for all of these babies born with congenital conditions who are being left by the wayside, who are being overlooked time and time again. I think we all really do want to work ourselves out of a job. We all want to be in a situation where our organizations aren't needed, because the treatment and care for these babies are embedded into the national health systems of your countries, those of you representing countries. We want to get out of the way. And we really are excited about launching this Global Action for Congenital Conditions. We want as many voices in the room so that we can all really take a step back and be in service of these children, these babies whose right to health care we are here defending above all. So thank you.
Thank you, Daphne. When you're talking about passion and not be focusing so much on the solution, I think that's a great suggestion to all of us. We all know what we want and how we want to do it, but really focus on the problem and join solutions is probably the best way to do it. I actually would like to ask the same question of Marika. Marika actually represents the private sector, and maybe you can say just a few words about what Remedy does, and how do you think the private sector can help with improving access, with improving policies. We know that in this field, without the private sector, without the industry, it's impossible to provide care. And so this is a really key stakeholder for all of us and for all the conditions that we're representing. So please.
Thank you so much, Bistra. Well, newborn screening is recognized as one of the most successful disease prevention solutions. So a small drop of blood at time of birth can be life-saving. Brevity has a long history in collaborating and partnering with governments and international health organizations, public and private, to make newborn screening more accessible around the world. So we are the world leader in newborn screening, serving customers in over 110 countries. Implementation strategies that have proven to be successful and where private sector can play an important role is, for example, setting up the pilot studies and targeting really the high impact conditions such as sickle cell disease, today sickle cell disease, or congenital hypothyroidism. We can identify and empower local champions. And also the integration, I think we learned today that the integration of newborn screening into the existing mother and child health programs is crucial. Also, it may be that opt-out policies should be implemented as a policy. The 77th World Health Assembly urged member states to implement universal newborn screening program. And newborn screening can save lives. It is simple and effective. However, still quite many newborn screening initiatives in low and middle income countries are largely project-based without sustained government support. So my one key message today is that let's transform these project-based initiatives to a successful and sustained public health programs.
Thank you. Thank you. That was wonderful. There's a word that we sometimes hear in public health that's called pilotitis, that you start so many pilots, but you really they don't translate into, and so I think that's a great message for all of us. The next question is actually for our other two speakers. I think you saw Ruben was introduced already, but it's a question about, do you have examples of successful models where we've had actually public-private partnerships? And I'm going to ask it maybe Dr. KK first and Ruben next.
Yeah, been very intimately associated with the public-private model that Mistra also and I work together, where we were able to, through sustained advocacy, get all the stakeholders together, get the government to play an active role, and bring in all the private care providers in the region to collectively take care of congenital heart disease, essentially with the goal of using this opportunity to reduce our infant mortality in our state of Kerala that was stagnant at 12 to 10 for many, many years, to try and then get it to single digit. Using that powerful message and knowing that congenital heart disease was one of the major contributors, we were able to get a collective endeavor involving all the stakeholders, but most importantly, getting all the private care providers to come to the table and agree to deliver that care. And it was a very successful model, which translated into an infant mortality reduction in the state of Kerala from 12 to 6 over a period of, say, 4 or 5 years. But just two additional points I wanted to bring, which hasn't happened so far here. There were the working on creating an infrastructure for all congenital heart disease has tremendous benefits in the health system outside of congenital heart disease. And we saw that happen with newborn screening. So screening for congenital heart disease identified lots of babies with respiratory conditions that received prompt care. They were then transported. You build transport systems for congenital heart disease, it benefits babies in having other problems as well. So trying to build the infrastructure and making a universal screening program has that benefit. The second point that hasn't been raised here is that congenital heart disease, congenital conditions happen together. So 30% of congenital heart disease has
other system problems as well. So I see a number of babies with cleft palate. I see a number of babies with club feet who also have heart disease. So that's a very strong case of us working together, because it does happen together and then becomes really difficult for this family.
Thank you. Thank you, Ruben.
You've heard me talk already, but at Operation Smile, there's a lesson that I've learned over the 40 years of engagement, 30 years of engagement with the organization. Our CEO reminds us that good judgment comes from experience, and experience comes from bad judgment. I don't know, that's maybe something that comes not only organizational, but in life. So we began by just wanting to take care of patients, or people, or children. And we realized we couldn't do it by ourselves, so we figured out we have to do more health support for health professionals, so more training. And we realized that wasn't really enough, so then we started to say, we'll invest in infrastructure and centers. And then that wasn't really enough, so then we said, well, we have to do more leadership engagement and advocacy and policy. Well, that hasn't really taken care of every child. So let's make sure that every programming that we do does health system strengthening. So all those things have been incorporated over time. But the one thing we saw from the very beginning as we were trying to take care of a child in some very remote area of the world is that we needed resources and we needed engagement from the health systems, from the governments that were destined or supposed to take care of people. And yet when you talk about public-private partnerships, governments and private sector might not always work together that well. But we realized that as part of civil society, we could be conduits for collaboration and unity based on trust and the knowledge that we could bring for the communities that were still asking for support. So our example of success might take us back to our investments in many centers around the world that have taken care of thousands of children, but it hasn't just been an organization. It has been our ability to go to the private sector and say, you know, you have CSR platforms and ESG platforms and all these things, but what you have beyond the definitions of all this lingo is people, because businesses, private sector is made of people who also want to serve communities. And we have engaged with governments as allies. So many ministers of health are so tired of us coming and saying, we have a problem. Oh gosh, another one, okay. But if we come and say, hey, we're here to support you, we have some solutions, there's an openness to it. So magic does happen. And again, I can think of one example in India where we showed up in Assam, one of the poorest states in the country, and a country that's so diverse. And the first time we're supposed to take care of 100 patients and 250 showed up. And then we said, well, let's take care of 250 and 500 showed up. And then they said, well, let's do 500. And then 1,000 showed up. And at some point, the chief minister said, okay, we get it. We have a challenge here. And that paved the way for collaboration for different companies that supported co-investment efforts that paved the way for, at that time, over 15,000 children to be taken care of surgically in 3 years, along with all the comprehensive care. And that is now continuing. And that is an example that replicates itself in 30 to 40 countries in which we're involved, and we're very proud of that. So we want to see more of that, and we're appreciative of private sector and the opportunities that government leaders open for us to be part of the solution.
Thank you, Ruben. We have just 10 minutes, and I want to make sure that we leave some time for questions from the audience, not just of these panelists, but of everyone that was here. I'm happy to take questions, and certainly of the leaders that we have on the panel right now and the previous presenters. Are there any? Yes, please go ahead.
Yes, so this is the coalition, right? We are the educational, the nurses who actually see this big, right? Who are in the community and have to reach environment, fragile areas, want to work with this coalition. But the question that runs in my mind is, how do we track success? How do we track accountability? Again, how do we work together without friction? This is really important to us because as leaders in this ecosystem, we find out that even organizations who are supposed to be advocates fight each other. They want to be in the same room with each other. So how do we go forward with that attitude? So my message is this: leave your differences and let's address the issue. The common thing that brings us together today is the patient. So let that common thing that brings us together band us together. We are ready to work. Nigerian government is interested in this, and they asked me to come take every note and bring it back to the nation. Thank you.
I think this was very exciting to hear that there are more countries interested. And this is what we've been hearing as, you know, I'll speak on behalf of the coalition, the Global Action for Congenital Conditions, is that there is a lot of interest. Certainly, we have seen it in our work with different countries and different partners around the world. But it's wonderful to see that these are not conditions, not diseases that are being forgotten, and there's interest from the governments. And as you see, there's real stories behind that. Yes, we have another question.
Fantastic discussion, and we're happy to be here. I'm Erin Stieber with Smile Train, and I really appreciated the mention of all the incredible work that you're doing to track the incidence of clubfoot. We've obviously been supportive in a few ways of trying to help develop registry systems. You didn't mention how you're doing it to ensure that we can others. What systems are we going to use? How do we use the same systems? Metrics for the to treat this issue.
And just before you answer, I want to point out that the WHO has guidance on that on their website and how countries can develop their own. So
Sure, thanks. Yeah, I'm happy to speak to the data system that Miracle Feet uses. It's specific to it's a point of care system. It's an app that clinics that are treating clubfoot are using as a way to track the enrollment of each child and then the treatment through the process, because treating clubfoot, there's a non-surgical way to treat it. It's called the Ponseti method, but it takes some time. So it's not like obviously a vaccine or something that you just do once. And it's so important, I think, as all of us who work and support ministries and health systems to deliver some kind of care or treatment, to ensure that that treatment is done in high quality, right? I mean, I think our one of our obviously non-negotiables is to ensure that work is happening and there's no harm to that child or that baby. And so this very specific data system, this is called CAST, tracks the progress of each baby at a very granular level, and allows our technical team and folks on our partners on the ground to monitor any kind of quality problems. So there may be, I'm looking at the Nigeria is a wonderful example. We have so many systems happening, and so we're tracking whether a clinic is having one of the KPIs is off by a percentage point or something like that. So it allows us to help and track outcomes. And that's always going to be a specific system to a condition. I think we all have to realize that there are going to be some systems around patient care that are going to be specific, whether it's to cleft lip or to clubfoot or something else. But that does not, I think, replace a health system policy of national level indicators that are tracking out the number of children and the incidence rate and so forth, which I think MOHs need to set policy, to allocate resources and so forth. So I think it's finding a way to connect the treatment level, the patient level treatments to a national health system type of national guide policy system that tracks more of the anonymized, randomized numbers. That help.
Others on the panel want to answer this?
Erin, I really appreciate that question. And hopefully you're celebrating as we are with the example of Brazil, in which President Lula just mandated care for children with congenital with cleft lip and palate, and also screening, detection, all of that we want and hope for. And yet what happens is there's a role that we can all play in making sure that happens, because that mandate, it's important, but we're still gearing up to go and train people as part of supporters of the health system in how to actually do the screening and the referral and the reporting, so that it isn't just a mandate. So the question is really important because it pushes for action and collaboration. So I appreciate that very much. So hopefully other countries will also do the same. I know Daphne was really proud, but I think that opens the opportunity. I think one of our patients or colleagues from the governments were talking about the spillover effect. If one can be done, it can be done for everybody.
If through the newborn screening programs, how do you integrate those with actually national registries, Marika? Is there something that a connection that happens that your model works?
Yeah, we have a data management solutions for newborn screening that takes care of everything from the sample collection, dry blood spot sample collection, all the way to reporting and patient care follow-up. I'd like to comment to Nigeria. So there's going to be in June 4th, there's going to be a meeting in Abuja, Nigeria Newborn Screening Consortium meeting, and it would be lovely if you could join. It is led by Dr. Aide Idu. Yes, she's a power lady in Nigeria, so you're more than welcome. And I'd like to kind of summarize of my newborn screening message that the newborn screening has a huge impact in health and welfare of a society. And it is not just a health intervention, but it is an investment in human capital development with a significant returns.
Comment, Dr. KK, about the program that Carol had in terms of data collection in Hurdayam, the registry.
I'll do that right after what you spoke. I completely agree. But in terms of newborn screening, we still should not be looking in silos. There needs to be a comprehensive program that integrates. It's very easy. There's a lot of screening that happens visually, and you can screen every organ system, because again, I keep saying this, they don't happen in isolation. Congenital diseases happen in clusters. They happen together. So we need a system that's comprehensive, that integrates metabolic screening, everything, thyroid, everything coming together in one whole package. Now, about the question of tracking data, and that can be very well integrated into public health programs that are directed towards, for example, in the state of Kerala, we had the Hridayam project that looked at congenital heart disease, but it wasn't simply just care delivery. It was looking through the entire care continuum, but capturing data as it went along. So the web registry was developed. Anybody could register the cases into the registry, and each case was tracked. Data was available in real time. And then eventually that fed into a really robust database that told us the whole story. How many were registered? How many got treatment? How many were treated in the first year? What are the surgical mortality? Every question was answered through that registry, and really powerful data comes out of the whole process. So what I visualize is something that's more comprehensive. We still are looking within our respective systems. I think it's all needs to be integrated together. And that would be the final, real great piece of us sitting together and working with diverse groups across many, many countries. But just I recognize that finally it's that one child. So we need to look at the human being as a whole rather than respective systems, individual systems within that human.
True that in India the system has a whole the head to toe.
Yes, the RBSK, the original handbook that came out is brilliant. It's really because I know the person who designed it, and I think that's the way to go about it. We still haven't embraced it universally, but it needs to happen.
Well, and I think that's it's true that what we're hearing here is that there's so much that different countries can learn from each other, and this is what we would like to bring. We want to bring together organizations, civil society, private sector. The WHO has this amazing technical specialist body that they have, and governments to really help countries develop better programs. Because I think, as we heard from the patient panel, these are real patient stories, real patients behind it, and whole families. And also, we're hearing from the panelists here that there's significant return if we save these lives. So I think with that, we should close it because we're a little bit over time. And yes, Natalie is going to come and close for all of us. Yeah, absolutely. Thank you so much to our panelists.
So, hi everyone. My name is Natalie Sheneman, and I represent the G4 Alliance. We're one of the founding partners of Global Action for Congenital Conditions. The G4 Alliance is also a coalition focused on advocacy and policy. So I'm here as a big champion of collaborative networks for advocacy, as was mentioned several times, and for integrating policy and services as a pathway to health system strengthening. This is difficult work, to your point, Bunmi, but it's truly essential. And this is what Global Action for Congenital Conditions, GAC, is all about. So before we close, I just want to say, give a heartfelt thank you to all of our speakers and guests today. Thank you to the WHO Department of Maternal, Newborn, and Child Health. I won't say your full department name. And Kate for bringing clarity and data and policy guidance to the table, and for braving all of the technological issues. Thank you to the representatives of countries and governments today who took your time out of your busy WHA schedules to talk to us about all of the great commitments and program models being implemented around the world. And a special thank you to Martha, Petra, and Amen for sharing your stories and showing us what is possible for improving lifelong care for congenital conditions when patient and family advocates drive the agenda. So thank you also to all the partners who made this event possible today, all the organizing. And we also do want to invite you to join us. So we have our small group of founding organizations, but we really want to grow in our expertise, grow in the different potential areas that we can be working together. So if you are an NGO, a social impact-oriented private sector business, or another potential partner, please scan the QR code, come talk to us. We'll send some follow-up information to everyone who registered today. Yeah, thank you for attending, and go off, and I hope you have a productive and enjoyable WHA.